I can confirm the webcast has started.
Thank you, Marie. Welcome everyone to this next HASC meeting, a meeting of the Health and Social Care Select Committee for Hampshire County Council. We've got, again, quite a long agenda this morning. So, first of all, can we go through the apologies for absence?
Sorry, it's Councillor Hiscock. I'm deputising this morning for Councillor Craig, who is unable to attend.
Yes. Marie, you've got a list of the absence. Councillor Briggs indicated to me last evening that she can no longer attend. We've got Councillor Carpenter, who is unable to attend. We've got Councillor Craig, who's unable to attend, and as Councillor Hiscock has just said, he's deputising for her. And we note that Councillor Hare will be joining us in about half an hour. Were there any other apologies, Marie?
That's it as far as I'm aware. I believe Councillor Burgess is deputising for Councillor Carpenter.
Yes. Right.
Chairman, was Councillor Briggs not due to join us later on?
Yes, she was, but she phoned me last evening and she's had to change her arrangement, so she won't be joining us.
Okay.
Okay. Right. So for the public record, I need to read out the names of people attending this meeting. So if you just indicate your presence as I call your name, that would be excellent. So Councillor Andrews.
Good morning, Chairman.
Councillor Boyles.
Good morning, Chairman.
Councillor Burgess.
Present.
Councillor Carew. Councillor Cooper.
Yes, good morning.
Councillor Dowden.
Good morning, Chairman.
Councillor Frankham.
Present.
Councillor Harrison.
Good morning, Chairman.
Councillor Hiscock, we know.
Yeah, here, Chair.
Myself and Councillor Keast. Councillor Penman.
Good morning, Chairman.
Councillor Quintrill is not here. Councillor Thornton. Yes, Councillor Thornton. Councillor Vaughan.
Good morning, Chairman.
And Councillor White.
Present, Chairman.
Right. Good morning to you all again. We can now move on to the item 2 of the agenda, which is declarations of interest. All members who believe they have a disclosable pecuniary interest in any matter to be considered at the meeting must declare the interest, and furthermore, all members with a non-pecuniary personal interest in matters being considered at the meeting should consider whether such interests should be declared. Are there any declarations of interest? No. Right, so now we can move on to the minutes of the last meeting. They should be on your ModGov machines. Are there any amendments or additions to the minutes? No. Are the minutes agreed?
Agreed, Chairman.
Yeah, Councillor Harrison. Sorry, Councillor Harrison, did you want to say something?
I just wanted to say agreed, Chairman. Forgive me.
Right, okay. I haven't had any indications of abstention or disagreement, so those minutes are carried. Deputations. We have no deputations this morning, and so next item is Chairman's announcements. I just want to formally record that no questions were emailed to me following the last meeting, so nothing arising from that. And I have no other announcements to make at this stage. So we can go on to the substantive item 6, which covers a number of things. The first item is the Hampshire Together Modernising Our Hospitals and Health Services, Hampshire Hospitals NHS Foundation Trust and Commissioners. And you'll see the relevant pages in your ModGov at pages 7, 11. The listening document is at page 17, and its analysis is at page 33. And we have with us this morning Alex Whitfield, who is Director of Chief Executive of Hampshire Hospital Trust. And I also note she has with her a whole team. We've got Ruth Coburn-Jackson, Managing Director of North and Mid Hampshire, Hampshire and Isle of Wight Partnership of Clinical Commissioning. And they are accompanied by Dr. Lara Alloway and Dr. Matt Nisbet. Also, we have present for communications Emma McKinney and Elliot Nicholas. I hope I haven't missed anyone out. Welcome, Alex. Are you going to lead us into this presentation scenario?
Yes, absolutely. Thank you so much, Councillor Huckstep. Yes, it's great to be able to come and talk to you again. The only person I think you didn't name was John Boyman, and he's going to be responsible for projecting slides. So hopefully he will be putting some slides up if the technology works.
My apologies to John.
That's okay, but thank you. So Hampshire Together programme, we have talked to you about it before. We very deliberately named it that, and the subtitle is Modernising Our Hospitals and Health Services. So it's not just about a new hospital. This is about how we provide healthcare for the people in North and Mid Hampshire for decades to come. So the team that's been working on this comes from not only the hospital and the clinical commissioning group, but also Hampshire County Council have been really helpful, the ambulance service, the community providers, primary care, borough and district councils, and a whole range of other people involved in this. The opportunity comes out of the government's programme for new hospitals, where Hampshire is in part of the second round, aiming to build a new hospital between 2025 and 2030. But as I said, we've been really keen that although the money's for a new hospital, we think of it as a catalyst for doing a lot more, transforming the way we provide healthcare and an economic opportunity for our population. So we've received £5 million to start developing the plan. We've updated you before about this, and we've explained our case for change, which is about our growing population, the condition of our buildings, the sustainability of our clinical services, and the financial sustainability of healthcare in our system. Those are our 4 drivers for change. And what we wanted to talk to you about today was where we've got to so far, the vision, the clinical models, some of the site options, the geographical locations, and some of the flow data about what it might mean for where patients end up, depending on various options. So I'm going to hand over to Matt to talk about the vision, Dr. Matt Nisbet, and then Lara's going to talk about the clinical options, and then you'll come back to me. So Matt.
Good morning, everybody. Thanks, Alex, and Councillor Huckstep. As well as being the CCG's clinical lead for business and partnership, I'm a GP in Basingstoke. So I think a number of you will have seen this slide before, and our central vision is to provide people with the right care in the right place at the right time. And whilst a large part of this project is about building a hospital, a large part of it is also about thinking about the whole pathway of people's care, the whole way that our patients and our people navigate their way through our health system. And we recognise the health system can be very complex and can be very difficult to navigate for our patients. So we're trying to think about how things work for them, both inside and outside the hospital, and how we could do that differently and better, both to improve outcomes, to reduce inequality, and to improve people's experience of dealing with the NHS. So if we think a little bit about how people access NHS services now and how we might be able to change that, I thought it might be useful just to talk about some kind of imaginary patients who might represent some of the people that Lara and myself see at the moment. So if we think maybe about the way that children's health clinics, paediatric clinics work, Traditionally, GPs have referred children to hospital outpatient clinics when we've got stuck or need some help, and those children will go along to the hospital and see the consultant or a member of their team. We think that in future that those children might be able to be seen somewhere other than a hospital, so at the GP's surgery, or possibly even virtually using technologies like the one we're using this morning. And in fact, during the COVID time, some of my colleagues have been doing three-way consultations with a GP and a consultant and the child at home with their parents, which makes life easier for everyone and cuts out a whole load of travelling. If we think maybe about somebody with sudden and very severe abdominal pain, a patient like that absolutely needs to be in hospital, but it's really important that the hospital they go to is properly equipped and staffed to deal with those kind of emergencies at any time of day or night. And lastly, if we think maybe about an elderly person with lots of complex problems, this is perhaps the most complicated of the three kind of patients I've talked to you about, and these patients at the moment very often bounce in and out of hospital. They get stuck between social care and healthcare, and we think that much can be done in the community to improve the way that we look after these people and improve the links between healthcare and social care. So it really is about providing the right care in the right place at the right time, not just about building a hospital. Moving on, I think Lara is going to talk to us about some of our models.
Thank you, Matt. Good morning, everyone. I'm Lara Alloway. I am the Chief Medical Officer at Hampshire Hospitals and also a consultant in palliative medicine. So we've been working hard with all of our clinical teams, as Matt says, in the hospital, but also outside the hospital, to really consider how we use this opportunity to develop our services to provide the very best care in the right place. And our models actually rotate around having an acute centralised hospital where we bring together our services that are the highest acuity, so our sick care for our sickest patients, and make sure that we do that, and we do that really well, with more consultants around, more doctors and nurses there to make sure they get the very best outcomes, whilst maintaining our local hospitals to provide the frequently accessed care. So things like outpatients, day case surgery, things like that. So this model has this acute centralised hub with the spokes of the local hospitals. So we also, as you'll see as I talk through the different models that we've developed, and this is an iterative process, so it's changing all the time as we develop and get more information and build up how this would work. But we have something called a planned surgery centre. So this is people requiring an operation, require an overnight stay, or it may be a day case operation. And actually, we recognise, and particularly our learning from COVID, that keeping these separate from people who are coming in as emergencies is really helpful. It means people's operations are not cancelled. It means it goes ahead. We can run it efficiently. When they're booked, they come in, they have their operation, they get the very best outcome. And all the staff are there to make sure they have the right rehabilitation, and then they go home. And we have something called the outpatient centre. So this is more than just coming along and seeing a consultant. It may be seeing an advanced nurse practitioner or a physio, but having the right investigations at the same time, and where possible, the treatment there and then. So we're calling this the outpatient centre. And then in the acute centralised hospital, this is where we have things like our emergency department, critical care, also known as intensive care, our obstetric-led maternity services, children's services where we have the children's ward, as well as cancer treatment centre delivering radiotherapy and chemotherapy. But as Matt says, all of this is working together with integrated care teams in the community the GPs working in primary care networks and social care, and all of that comes together. So these are the different building blocks of our clinical model. And as we go through the model, the options, you'll see that we move the planned surgical centre and the outpatient centre between the local hospital and the acute centralised hospital. So if we move on to the first option, in this configuration, you see we have the acute centralised hospital, and then on the main local hospital site, we have the local services. So an urgent treatment centre sees about 75% of the people who currently come to the emergency department in Winchester. But we also provide outpatients, the diagnostics, so scans, endoscopy, blood tests. We have step-down rehabilitation care, so people who need a longer hospital stay where we can't discharge them to have rehabilitation at home are nearer to home. We have a midwife-led birthing unit so that actually people can continue to receive all their antenatal and postnatal care locally and have the choice where they're not high risk and they don't need consultants present, that they could have their babies in Winchester. We also provide day case surgery in the local hospital. So this is something that people need locally. They come in for the day, they have their operation and then go home again, as well as hospice services. And as you'll be aware, we're building a hospice even in Winchester. And for this option, the planned surgical centre is on the local hospital site, but actually is separated to ensure that we can protect and make sure that people book for surgery have it in a timely way. And then if we move through the second configuration, the planned surgical centre moves to the acute centralised hospital. There are pros and cons, and obviously we need to think about accessibility for people. There are advantages of planned surgical centre being co-located with critical care. We don't have to be so careful about the people that are coming in there and making sure they're unlikely to need the extra support of critical care. But obviously this is less accessible for part of our population. So in this configuration, we have the local hospital just with the local services. But when I say just, that's actually the majority of the frequently accessed services. And then in the next configuration, we split the outpatient centre between the acute centralised hospital and the local hospital and keep planned surgical centre at the acute centralised hospital site. And then you're getting the hang of this. Configuration 4 keeps the outpatient centre split but moves planned surgery onto the local hospital site. So again, advantages around accessibility, absolutely protecting this area so that there's no cancellations, really efficient service that can be run, but we have to be careful around the people that have their operations there, making sure they're very unlikely to need access to critical care. If they do, we can stabilise them locally, but we would need to transfer them out. And then moving on to configuration 5, we have the outpatient centre just on the local hospital site and planned surgery in the acute centralised hospital. And then moving on, again, we also have the other options of what some people call do minimum, but for us that is some essential service reconfiguration. So this will be the option of keeping our current hospitals on their current sites, doing the essential backlog maintenance, which is very, very significant, but also making sure we have reconfigured the most at-risk services. And as we have talked before, when we last spoke to you, our most at-risk services are neonatal services, and there is from the neonatal network a need for us to consider either centralising or redesignating our services so that we look after older babies and the younger, more at-risk babies would go to other sites. And staffing our emergency department is really very difficult for us to staff 2 small to medium-sized emergency departments. We have some surgical services that we see the advantage of centralising to improve outcomes, to improve the efficiency with which we run them. So the essential service reconfiguration keeps the existing hospitals, but there will be some change to our services. Through the process we've been through, and some of you on the call have participated, and thank you very much, we have discounted some options. We have discounted business as usual, doing what we're doing now, and for all the reasons we spoke to you last time. But we've also discounted running all of the services from one location because we recognise that this does not meet the needs of the population. So that covers, in a whistle-stop tour, the options work that we have done to date. We've got a further whole afternoon working on this. So this is changing all the time. But I'll hand back to Alex.
Thank you, Lara. So that's the options about clinical models. We've then got the site options. So this is the site of the new hospital, and we've been through a 3-stage process. The first one was we commissioned people to scour the whole county looking for any plots of land that were 40 to 50 hectares big. They identified 9 sites, which included some in Basingstoke, Winchester, Micheldever, Sutton, Scrutiny and Andover. So they really were over the whole of the catchment for Hampshire hospitals. We then ranked those sites using 36 different criteria, which involved whether we'd like to get planning, how close it was to the road network, whether there were environmental risks with the site, and a whole load of other things. And we ended up with 5 top-ranked sites. The stage 3 was then to go and talk to the landowners of those sites to say, are they available to purchase? And if so, in what timescale and at roughly what price? Is it reasonable? And the end conclusion of that was that only 2 of the sites are available to buy, meet the criteria of being accessible, planning is likely to be available and so on, and would be available in the time and at a price that is sensible. There was a bit of a moving of one site got added and another one, and so we kept it open, but we ended up with 2. The 2 that we've ended up with, the first is land near junction 7 of the M3. It is a greenfield site. It has advantages of major road links, of being kind of right in the middle of the patch, so accessible from Winchester and Andover and Alton and other places, as well as from Basingstoke. And a greenfield site has some benefits of us being able to build the hospital, in the way we would want to build it. The second site is adjacent to the current Basingstoke and North Hampshire hospital site and would involve using the current site and the adjacent land. It has benefits of already being on a public transport network and of being a site where patients and staff are used to going, clearly from the Basingstoke end of our population, less so from Winchester and Andover and Alton and Eastleigh. It would mean that we would buy some land, build a bit of a hospital, knock down something existing, build on that bit, knock down a bit, build on that bit. So it could potentially take longer. However, it's already got all of the electricity and sewage and water. So there are pros and cons to both of these sites. And so our decision is to take both these sites through the public consultation process that we are hoping to run in January, February, March, and understand from the public what they believe would be the pros and cons of each of these 2 sites. So our consultation is going to include the sites, these 2 sites for the new acute hospital, and also the clinical models that Lara's been talking through. So I'm going to hand over to Ruth now, who's going to talk a little bit about patient flows, i.e. what that means for where the population goes, and also the scrutiny process, because that's really why we're here, is to ask you guys about what you want to do in terms of the scrutiny process for this programme. Ruth.
Thank you, Alex, and good morning, everybody. So my name is Ruth Colburn-Jackson. I'm the Managing Director for the Clinical Commissioning Groups for the North and Mid patch. So hello, everybody. So I'd like to start with a little bit of data, if I may. So the first one's a rather lovely map, and this shows what we're calling our study area. And you can see the geography there, so it covers our Hampshire patch. And it represents about 1 million population, so resident population about 1 million people. And just give you a moment to orientate yourself to the colours and the pictorials here. So we can see that what we're trying to show here is how our patients across our Hampshire geography will flow into our different provider organisations. So you'll see the green bars are the Hampshire hospitals bars. So that shows resident population of Hampshire accessing acute services from Hampshire hospitals. You'll see the red bars are for University Hospital Southampton. The purple bars at the top are patients accessing services out of Frimley. The blue bars are for Portsmouth, and so on and so forth. So you can see the vast majority of our Hampshire population do actually access services within Hampshire hospitals, and for around the edges, we also flow into different providers, particularly our partners in University Hospital Southampton and also the Frimley geography. And of course, that's really important to us because our intention through this programme is to still serve the population we presently serve through Hampshire hospitals. So this is a really important piece of baseline activity for us to understand, to make sure that we understand the changes of any of those potential flows for any of the options that we put forward through our consultation process. Clearly, another part of information that we wanted to share with you is our close working with our partners in those other provider organisations. So we have really strong relationships with our University Hospital Southampton colleagues and working very closely on the programme with them in terms of any impact that we may be having around their services and their sites, and similarly up into the Frimley geography particularly. So those two areas we're engaging very clearly with our council colleagues, other local authority partners, other provider colleagues, as well as clinical commissioning groups in those patches. So it's a really important piece of work for us, and to understand the impact of any of these changes on both our residents, our staff, and our other provider colleagues is of course really important to us. So next slide, please, if we may. These next two slides are just going to tabulate some of that data for us to help us understand the current flows in terms of into our Hampshire hospital services. So as we can see here, this shows the percentage of patients who live within a North and Mid Hampshire resident area who access services into Hampshire hospitals between 2017 and 2020. And the important thing here for us to see is the static nature of those flows. So we can see that at the top line for the inpatient activity, around 82% of patients who flow into Hampshire hospitals are resident within a North and Mid postcode. So that's quite a high proportion. Similarly, for outpatient activity, it's slightly lower. We'd expect that because patients do tend to go to other geographies for specialist services or other routine pieces of care. Any activity, again, or accident emergency activity, very static around the 80% mark over the last 3 years. And similarly for maternity services, again, around 87–88% of those patients are using Hampshire hospital services. And that's really important for us to recognise again in terms of our baseline, because one of the most important pieces of work for us to do is to understand how the options may impact on some of those flows for our patients. So are we still serving those patients, albeit in a different model or in a different place, but we're still serving those patients for those core services that people are expecting to access. So if I could have the next slide, please. The next one looks to cover the whole of our county patch, so the whole of our unitary authority area for Hampshire, and again across those 4 key domains of care or key routes of service, we can see that they are again broadly static over the last 3 years, and it shows that around 90% of our patients who access Hampshire hospital services are resident within the Hampshire geography. So again, we are a large and a real mix of urban and rural geographies. So understanding how those flows work presently is really important to us. Something that Alex has alluded to, and also Matt and Lara when we've talked through this morning, is being really clear about the opportunities for local services. So this is about building a facility, but it's also about being really clear about those opportunities in our local geographies to think about what else we can do to enhance those services and enhance that care model alongside the rest of this programme, which is of course around the building of a new facility. And it's really important that we remember that, particularly given the scale of our geography and the rurality of some of our places. So thinking really thoughtfully about how we serve those populations in an enhanced way as part of this programme is a really core piece of our work. If I can move on to the next slide, please. So this is a really important piece for us now, and in a moment I'll step into the next steps which talk through the overall areas of work that we'll be taking ourselves through over the next little period of time. But of course the scrutiny process is really important, a really important conversation for us to be having with you today in preparation for that formal period. So of course our local authority scrutiny bodies we've been in contact with, including yourselves, both in writing and also coming to speak with colleagues, and you'll see there the range of colleagues who we have formally engaged with around this next bit of process. And the question we ask is, do you wish to be briefed, or would you like to be a formal part of that decision-making process and form a joint committee? And we have so far received, thankfully, responses from everybody. Southampton have confirmed that they would like to be part of a joint formal committee, and Surrey have confirmed they'd like to be a standing observer. Others have declined at this stage, but of course we keep that communication open and we'll continue to brief and engage, although they don't wish to be part of the formal decision-making process. So that's important to note for us at the moment, that we do have a firm commitment from Southampton in terms of formal decision, and Surrey to stand and observe. So the next slide, please. So in terms of next steps, of which formal scrutiny forms a part, and we'll need to discuss and liaise with colleagues to be clear about when that process will need to happen with regard to a joint health committee process. So we are presently in November, and we are currently going through the process, as Lara alluded to, in terms of our options development, and we're taking some formal steps in terms of our shortening of our long list at the present moment. So, and we have a weekly process, which is an engaged process with clinicians and patients, as well as our staff groups, and then coming into place, so we have a full pre-consultation business case written up, which includes those options, with a view to coming out to public consultation early 2021. And around that time is when we'll be looking for that formal scrutiny decision process with colleagues from local authority. In mid to late 2021, following that public consultation, and once that has been run, we then look to take a full decision on the service configuration and the location. So that's where we create a decision-making business case. And again, that's the next formal juncture, and that will be sort of summer into autumn of 21. And then 2022 to 30, we go through the networked care process and make sure that we've got that planned as part of our full transformation plan. And then if the new hospital proposal is agreed, we then begin to work 2022 to 25. And then again, if the new hospital is proposed at that point, we then go through to opening in 26 to 30. So as you'll see, there's a really a load of work in very short order, and then the timelines expand out as we look to start building facilities. But hopefully that's a helpful indication of where we are presently, and the engagement we're grateful for from colleagues in Hampshire with regard to the next steps around formal consultation and scrutiny. So I'll stop there if that's okay, Councillor Hackstep.
Thank you very much indeed for a comprehensive briefing on what is actually a very important topic, not just for you, but for all the residents of Hampshire, and in particular this morning the HASC, because we need to make some important decisions about your project. Let's call it the Hampshire Together project, because that's what it really is. So thank you for your presentations and bringing along, Alex, a comprehensive team to answer any questions that we have. Do I have any questions from members?
Yes, Chairman. Councillor Dowden, Chairman.
Councillor Dowden, go ahead.
Yes, thank you, Chairman. I appreciate there's a tremendous amount of work that's taken place here, and it's quite a comprehensive, if you like, situation, because it's a large population and you try to achieve something. What I'm concerned about, I suppose, if there's any concern, is that whichever location you finalise, there will be people opposed to it and people supporting it, whatever you do. I appreciate that. But what I am concerned about, you're starting in 2021 with the consultation to the public. I've listened, and obviously I've got perhaps a little bit more knowledge than some members of the public. How are they going to understand all this in regards of answering any consultation? It isn't going to be easy. And how are you going to, conduct this?
So we do have, I think, Emma McKinney, who's the communication lead for the CCG. And I don't know, Emma, if you're, or Elliot, one of you is best equipped to describe the consultation, because it's a very comprehensive programme, hopefully explaining clearly to people so that they can engage. Emma or Elliot, did you want to pick that up?
I'm very happy to start, and Elliot can add to anything perhaps I miss. So hi Hi everyone, I'm Emma McKinney. I'm Director of Communications and Engagement for the Hampshire and Isle of Wight CCGs. So Councillor Dryden, I think you make a really important point that this is really complex, and making sure that we describe it and explain it to our public is paramount. So there are a number of methods that we will use to do that. The central one being a consultation document, which will set out really clearly and in plain English what the options are and what we're asking people to consider. And we'll also use live case study examples of what that might mean for, you know, Mrs. Smith in each particular scenario, to try and really spell that out. We will obviously, of course, have some public meetings that will go alongside that. Now, obviously, in the environment that we're in, they will most likely be virtual in the same way that they were during the engagement phase, but that will allow people the opportunity to talk through directly with some of our clinicians like Lara and Matt and so on, to talk through concerns and get a real understanding of what these proposals mean. We've also got things such as animations and video to talk it through, because I think where it makes more sense, as we've said, is describing it in real live case study type examples to really underline for people what it's going to mean in reality. So that's just a flavour of some of the activity. We'll also be doing podcasts, you know, lots of media coverage. As you've said, it's going to be extremely you know, popular, and I think we'll get a lot of coverage. So we will do everything that we can, but feedback is going to be really important as well. So I suppose a plea from us to say that if there are things or forums that you think it would be helpful for us to join, or you know, methods that you think that you're hearing from people about issues that they're finding it difficult to understand, or that we could perhaps do better, then throughout the process we're very happy and would be very open and welcome to receiving that feedback. So I hope that helps describe some of the process that we're going to be going through.
Thank you. Can I just come back on one of those things? Is that one of the ways forward, apart from the general public, if you like, is the local health forums. It's like the one in Romsey, which I attend, because there's a number of organisations involved with those local health forums, and they push that information out to their members as well, and whatever. So those are the sort of things that perhaps people should come and give a presentation or something, or whether it's virtual or you know, if with this wonderful vaccine, maybe, you know, in the new year, maybe we will be stepping forward again and meeting up, who knows. But those are one way that I think could help.
Absolutely, and we're very keen to come to any of those sorts of forums. So we've got quite a comprehensive list already from our engagement phase, but certainly if we've got any gaps and those sorts of things, then by all means, please do share details, or we can come perhaps through Marie directly to get details of those in your particular patches. That would be extremely helpful.
Thank you.
You're muted, Roger.
Yeah. I am muted. I'm not muted now. The next question comes from Councillor Keys. Thank you.
Thank you, Chairman. I just want to refer to page 7 of your listening document, which is for members, is page 23 on your order papers, and it refers to the condition of buildings operated by Hampshire hospitals. Now, looking at that, I'm not surprised you want to build a new hospital. You say that you need to bring your buildings up to scratch. You need to spend £73 million, which is 3 times the national average, and that to keep them going until for the next 30 years will cost you £700 million. Well, 2 questions. How on earth did they get into that state in the first place? And secondly, are you going to just close them all if you get a new hospital so you don't have to spend this money? Well, if you're going to keep them open, where are you going to get the money from?
Thank you. Yes, good question. So how did they get into this state? Well, Basingstoke Hospital opened in 1972, and the worst bit of our estate in Basingstoke is the main tower block, for anyone that knows the building. And most of the buildings that were built, that were opened in those 60s and 70s, have already been pulled down. So we have invested in bits. We're repairing the roof this autumn because the roof onto G floor has been leaking for a number of years. That's costing us about, I think it's £500,000, that sort of order of magnitude, which we have to spend because we cannot wait the next 8 years with buckets on our children's wards. But things like the sewage pipes, the wall thickness of the pipes in 1972 was something like 1 centimetre. We're now down to millimetres in wall thickness, and that's just the age of the pipes. So they're just getting to the age where they need to be replaced. So much of this is the age of the building, and there was little we could have done to prevent some of that decay. In the Winchester Hospital site, the worst buildings we had were the old outpatient area, which were kind of almost looked like temporary buildings for anyone that knows that area on the front of the Romsey Road. We have emptied those of all bar a couple of services, and the plan is to move the last remaining services into newer bits of the building over the next 12 months. So that backlog maintenance cost, we will not be repairing those buildings. In fact, we've sold some of the land to the University of Winchester already. So we are trying to minimise what we need to spend. In terms of the question about are we going to continue to operate services out of the existing sites, the plan is that Winchester, the Royal Hampshire County Hospital in Winchester, we will be continuing to operate services out of. There are some parts of that building which are actually not in bad shape. So the Burrell wing, which is where our brand new outpatient unit is, and our day surgery unit, that's actually built in the 90s, is in quite good condition. And so what we're going to be doing is looking at how we invest in that site, but also how we maximise use of the good bits and potentially some of the less appropriate real estate we have to move out of. The Basingstoke Hospital site, if we choose the Basingstoke Hospital site as our future site, then we will be, as I said, building a bit, knocking down a bit, building a bit, knocking down a bit. We will effectively be replacing the whole building. If we choose the Junction 7 site as the site, then there are some options. At one extreme, we knock down the whole of the current Basingstoke North Hampshire Hospital site, and that land's available for housing or economic development or whatever. But as part of our consultation, we do need to understand whether there are some services that the population of Basingstoke would want kept there. And we're working with primary care about that. But we would imagine they would be pretty minimal. And the main tower block will be coming down, I think, either way. And then Andover is our third hospital. It's a smaller hospital site. It has some really beautiful bits of real estate. The new hospice is stunning. It has some other bits that are old. The worst bit was the health centre at the front of the Andover Hospital site, and we have received some money already to rebuild the GP practice that's housed there, to rebuild a facility for them adjacent to the actual hospital, the Andover War Memorial Hospital, and then we will be decommissioning that front of the site. So we're kind of going through trying to take things out of service rather than spend lots of money on them where we can.
Thank you.
Thank you, Alex. Next question comes from Councillor Harrison.
Yes, thank you. You seem to have a high level of confidence that the necessary money will be there available for you to deliver what you're charged with doing. I have to say I'm not incredibly confident that it will be. I've noticed that there's no price attached to any of your options, and I think if I was being consulted on the matter, bearing in mind the pressures on government with the COVID response and all the outflowings of money, I think I'd probably go for the cheapest option on the basis that this is the most likely to be delivered. So I wonder, as the consultation goes forward, is there merit in putting a price on these things so people can make their judgment about, the likelihood of these things going ahead?
It's a really good point, and part of what we needed to do in terms of getting down to fewer options was to be able to do the detailed price, or a better level of detail. It won't be the absolute detailed level of pricing, but a better level of detail of pricing. So we are going through that process, and there's sort of two aspects. One is the pricing of the build work and how much it would cost to do the various different building options, and then the other is the ongoing cost of running healthcare in whichever configuration. So we know it's more cost effective often to centralise services. You're not trying to run 2 teams of 24/7 on-call staff and what have you. It's often more cost effective to run it from one site for some of the high intensity, high acute services. And also a new building, one would hope, would be cheaper to run. You should be able to build it more environmentally friendly with lower energy costs and so on. So what we're trying to do is look at the capital costs of the building in each option and then the knock-on revenue. And you probably won't be surprised to know that the things that cost most in terms of capital, which is put lots of things into a big central new building, save you more money in the ongoing running costs because the staffing of that's then cheaper. But we've got to have a balance between that because we don't know how much capital money will be available for building in the time. We've been given some indication, but we haven't got an absolute number. But we also want to provide cost-effective healthcare services going forward. So all of that information will be available for the consultation, and it will be included in the information we share about the options. But we just haven't quite finalised all of the maths yet.
Okay, thank you.
Can I just come in on the money slightly? I mean, I think it's a really interesting point, the money, and the money is really tricky. But as councillors and public administrators, you know, I'm not surprised in what you say that you would choose the cheapest option. But I suspect if we asked our patients, they would probably choose the most expensive option. So I think we have to be a bit careful about the money. I mean, it's probably interesting for you to note as well that in our conversations with central government, that they haven't given us a kind of price tag to work to, if you like. So it is very much, as Alex said, about achieving the best value over the lifetime of the project, which is 30, 40, 50 years, really.
Thank you for that. On the question of money, yes, capital is important, running costs are important. I think the evaluation really should go with the through life costs of the venture, because that's the total amount of money. And by looking at that very carefully, you'll be able to see what the projected real savings are in the future. I don't know whether that's part of the Treasury's Green Book philosophy or not. I hope it is. Right, next question is from Councillor Cooper.
Yes, good morning. I'm representative up in the northeast of the county, and I just would like to get some clarity from you for my own mind and just to see how things are working out here. Rushmore feeds at the moment into Frimley. Under your grand plan here, will that continue, or are you looking to move the catchment of Frimley, which is what, 250,000 people, into the new Hampshire Together project?
Ruth, do you want to pick that up?
Yeah, more than happy. Thank you, Councillor Cooper. And yeah, really good question. And our intention for this programme is to continue to serve the population that we presently serve. So that's our overriding intention. Now, clearly, depending on site locations, there are considerations around how we recognise some of those potential impacts for some of our populations. But we are working very closely with our colleagues in the Frimley system, both across the clinical commissioning groups and Frimley as a provider organisation, and connecting in through. So we work closely with Hart and with Rushmore from a sort of with other pieces of project work collectively with our North East Hampshire and Farnham colleagues from a commissioning perspective as well. So that the links are there and the communication is there. What's really important is that we understand our baseline in terms of how our patients are presently accessing services, and make sure that whatever we do in our new options have mitigations for any of those unintended consequences. We need to understand the potential consequences and then be clear with colleagues about what those mitigations are. But our intention is to continue to serve the resident population we presently serve.
Okay, thank you. The reasoning for my questioning is, if we look at Farnborough, Aldershot and Fleet, for example, we'll mostly feed into Frimley Park, which is, as you well know, a centre of excellence throughout the country. And if I take my own specific case, for example, I'm about a mile away from Frimley Park, and obviously, I don't think residents of this area would really want to be heading off in the direction of what looks to be probably Basingstoke.
Yes, so again, our intention is not to start moving our resident population's care around. It's absolutely about continuing to serve as we presently do, and Frimley's intention would be the same, Councillor Cooper.
Thank you.
Thank you.
Thank you. I note that we have Councillor Grajewski with us, who is the Executive Member for Public Health, and indeed also Councillor Liz Fairhurst, who's Executive Member for Adult Social Care. And I see that, Judith, you want to make an observation. Please go ahead.
No, I'm not a member of the committee, so as far as observations are concerned, I'm going to restrain myself, but I do have some questions. Firstly, this should be an easy one. On page 23 of the agenda, which I think is page 7 of your report, it says down the side of the first column, it's talking about financial resilience, and it says, for instance, the local health system struggled financially in 2019-20 with Hampshire hospitals in particular, ending the year in a, and it's very tempting to fill in the blanks, but I just wonder what words were meant to be there. Have you found that?
Judith, I think we missed the critical part of your last sentence. Would you like to repeat?
Yes, at the bottom of about halfway down page 23 of the agenda, page 7 of the document, it's talking about financial resilience, and it says, for instance, the local health system struggled financially in 2019-20 with Hampshire hospitals in particular ending the year in a blank. I could put in my own words, but I'd like to know what's meant to be there.
So we ended the year in a deficit position. We overspent versus the income. So that's how that sentence should have ended. Apologies for that.
I was wondering late last night.
Yeah.
I also wonder if you can tell us what preparation Southampton hospitals that would be considering if A&E, rather than being having to bring patients from Basingstoke to a new A&E in Winchester, if Winchester and Eastleigh patients had to go to Basingstoke, what would happen is that particularly in Eastleigh and the south of the borough, people would go to Southampton. Is Southampton ready to cope with that? South Central Ambulance Service, if A&E is put into a single location, either in Basingstoke or in Winchester, this will, I think, mean more journeys and longer ambulance journeys. So what will the impact be on the ambulance service? And finally, in terms of access, we've heard this morning, you say that it says in the paper that access or the A&E would have to be within reasonable reach. Now, Winchester Hospital is of course quite close to the railway station and there are good bus routes. That isn't the case with Junction 7. You mentioned roads, but not railway stations or buses. We are, as a society, moving to more active travel and planning for movement of people rather than movement of cars. So what do you think is a reasonable time to have to travel to an A&E? And thinking about the people in society who are less fortunate, what is a reasonable cost? Because public transport doesn't come cheap. So could you put some figures on those, please, at what you think is reasonable for people to expect to have to pay? Thank you.
Thank you. So in the interest of time, if I just take those quickly and we can expand on them more if needed. So Southampton Hospital are really engaged in this programme. And I think one of the things that you're right, they are anxious if it means they get a lot more patients. But what we're working with our GPs and community providers and the ambulance service to do is to say that the vast majority of people should still be able to access care at Winchester or close to home. And there's a big programme running out at the moment, 111 First, that I think you've probably heard about at the committee as well, which is about saying for most urgent care needs, if you can call 111, if the ambulance takes you, that's fine. But if you are going to be making your own way, actually you could get booked into an appointment. And what our vision for the Winchester site would be that there would be loads of services that you could still access at the Winchester site. So you could get same day access to a consultant or to a scan or to a physiotherapist or to lots of different people. So actually the impact on Southampton should be minimal. And as Ruth said, our ambition is to continue to look after the same group of patients that we look after today. The ambulance service have been very engaged. They actually would rather we co-located on a single site. I know the maths would say that means they're going to have to drive slightly further, but from their perspective, having one site where they take everybody and go to and from makes managing their fleet much more straightforward. So they are very supportive of this. They were supportive of centralising the ambulances way back, 10 years ago or 7 years ago when we look at this, and we've just come off a call from them. They're still very supportive of this programme, as long as we can guarantee that when their ambulance arrives, we can offload their patient very, very quickly and their ambulance is then free to go back on the road again. But we are involving them. Public transport, I think, is a key one. So of the two site options, clearly the current Basingstoke Hospital already is on a public transport network, but the Junction 7 one isn't because it's currently a field, and why would you have public transport running to a field? But we are working really closely with the borough district councils and the county council and Highways England and anybody else to talk about how do we get good public transport routes to that site, should that be our preferred site. And I think you're right, the train links is a part of that. You may have seen the Basingstoke and Dean publication recently about their vision for that part of Hampshire, and they include things like a mass transport system and a variety of other things. What we need to do is make sure that that mass transport system, should it come into effect, isn't just from Basingstoke to Junction 7, but how do we actually make it part of Winchester, Andover, Alton and a whole load of other places. And then the cost of it will be really important as well. There is already a system whereby people can claim the costs of transport to getting them to healthcare facilities if they are in receipt of particular benefits and things like that. But I know often it's people on the margins who aren't quite in that position, but their budgets are stretched. And so we need to incorporate all of that into the consultation. It has come up a lot, and we need to make sure we've got solutions to that through the consultation. Thank you.
Thank you.
Thank you, Alex. Now, look, I'm aware that you wish to be leaving us at 11 o'clock, which is sort of 2 minutes time. Is that still the case?
I'm afraid I do. I've got an all-staff briefing, so I can't, but I can leave you in the capable hands of my colleagues.
Yes, I'm sure you can. Thank you very much indeed, Alex, for being with us, and we'll be catching up with you, obviously, in due course, and we'll let you know the outcome of the recommendations of this particular agenda item. Thank you all.
Thank you.
And Councillor Keith, did you want to ask another question?
Well, it was just an observation that you and I made yesterday regarding the committee that's going to be steering this through, and I note that Southampton are going to be invited to join it. And when we looked at this, there was a possibility that Southampton could have two seats or two places, two people on it. And then we read that the quorum was likely to be 3, which would, in certain circumstances, might give Southampton the control over your project. So it seemed a bit, what's the word I want? It seemed necessary really to perhaps make the quorum 5 if you're going to have 2 people from Southampton, rather than 3 if you got so that you have control over everything.
Yes, thank you, Councillor Keith. We did discuss that, and it'll come up later in the meeting when we determine the recommendations for this item on the agenda. Are there any further questions from anyone on what we've heard so far? Because otherwise we can then go to the recommendations. Right, I don't see any indications. Now, it's very clear that the project has got to the point where they've narrowed down the site options, and they've narrowed down the, if you like, the service options. None of those options have been declared as the answer. That's why there is going to be a consultation process in the new year, and that's why the possibility of a joint scrutiny committee is in the offing, and that's what part of this agenda is about. So what we have to consider is whether the proposals do constitute a substantial change to health services. Now, I think without even asking the question, I think we can probably all agree that we are talking about a substantial change. Does anyone disagree with that? Okay, so we've approved recommendation A. Now, the next one is to request that either the HASC or the Joint Scrutiny Committee, if established, have the opportunity to comment on the plans for public consultation and proposals. Well, clearly we would wish to make that request, would we not? Anyone disagree?
Agreed, Chairman.
Agreed. And item C, note that if a scrutiny committee is established, the proposals will primarily be scrutinised by that committee and updates on progress be reported to the HASC by the joint committee members. Is that agreed?
Agreed.
Agreed. Now, on your ModGov devices, you'll have seen yesterday Marie sent out a proposed terms of reference, a draft terms of reference for such a joint committee. Now, what we want to do is this morning, if we can, is agree in principle those terms of reference, but the detail of them will have to come a little bit later, because obviously we will need to determine whether other local authorities want to become more involved or not. At the moment, we've had an indication from Southampton that they would like to take part. We've had an indication from Surrey that they'd like to observe, but they're not the only local authorities. And as this project moves forward, they might be, other local authorities might be stimulated into taking part. So can we agree in principle adopting these terms of reference, and the detail of them we will agree at a later date. In any event, because of what we've agreed so far, we are going to have to present to Council in December a paper which will constitute the establishment of the joint committee, so that it can be, as it were, a legal entity within the County Council's work. Is that agreed?
Agreed.
Agreed.
Good, good. In that case, I think it's fair to say we have sorted out item 6A. So what we can now do is thank very much the attendance of all the people that Alex has brought along. Thank you very, very much for your input and answering the questions. And I'm sure there will be further questions. You'll probably know, as part of a procedure within this committee, members have the right afterwards to email questions in, and then we feed them out to the relevant organisations to answer them. So once again, thank you very much indeed for your attendance, and you can stay online and look at us, but I'm sure you've all got lots and lots of things to do, and we wish you well over the next few months, because this lockdown is not going to be much easier at all than the last one, and all our NHS personnel are under a lot of strain, as we see nightly on the news. So thank you very much indeed for all your work and all your future work.
Thank you.
Right, I think this will be, I think, a good opportunity to have a 10-minute break. We normally have a break within the first 2 hours, so we're halfway through now. That was quite an exhaustive little agenda item. So let's have a 10-minute break. We'll meet again at 11:15, and we'll move into the second part of item 6, which is building better emergency care programme. Thank you, Marie. Welcome back, everyone. I hope you've had a suitable short break. We can now resume the meeting at item 6B, which is Building Better Emergency Care Programme, Portsmouth Hospitals University Trust. And we have presenting Penny Emmerett, who is the Deputy Chief Executive of Portsmouth Hospital Trust. Are you there, Penny?
I am, Councillor, yes.
Thank you, Penny. Please go ahead.
Excellent. Good morning, everybody. If I may just give a brief introduction to the paper, just to pull out the salient points, then of course very happy to take any questions. So just to give a bit of background, we were last at the committee in July 2020, where we were updating the committee on our plans to improve the emergency care facilities on the Queen Alexandra site. Since that point, we've shared a stakeholder briefing in September, which was following confirmation from the Secretary of State for Health and Social Care that our strategic outline case had been approved. Just in terms of some background on the case itself, the capital investment gives us an opportunity to redesign our emergency care to ensure that we're able to offer timely access and care for all patients who require emergency care, minimising handovers, duplication and delays. We are working across our health and care partners to tackle some of the long-standing challenges that you will know that have contributed to delays to patients over the years. And one of the things that we're talking about next, actually, in terms of your agenda, the 111 First initiative, is an example of improvements that we are already making around emergency care in advance of any changes to the estate, which we're talking about here in terms of building better emergency care. So just to draw out for you what's happened since the approval of the strategic outline case. So we have appointed a preferred supplier chain partner, Integrated Health Partners. So we're really pleased to have their experience on board with us to progress the designs for our new emergency facility. We've also identified a preferred site that takes into account a number of factors. So both the space requirements that we need, the need for clinical adjacencies with services in our existing estate, phasing, disruption, value for money to make sure that we're spending the money in our clinical estate as opposed to having to spend significant amounts on infrastructure or changing access to the site. That preferred site is part of our East car park, which is currently used for staff car parking. We've also updated the timelines for the programme, so we're expecting to submit the next stage of the business case, the outline business case, in early 2021, and anticipate that we'll have the facility open to patients in 2024. So the capital investment is looking to enhance the current provision of services rather than change their nature or location. So they'll all still be provided from the Queen Alexandra site. We're carrying out engagement in the coming months to inform the clinical model and the design principles, but in the later stages we'll have greater engagement activity that will help to inform the detailed design. And of course, you can take our commitment to continue to engage with patients, public, staff, committee members, partners and our community as part of this ongoing work over the next few years. So just to note, I've referenced the car parking already. So all patient car parking impacted by this development and the other developments referenced in the paper will be replaced on the hospital site, and a traffic solution will be included as part of the design. So linked to the other scheme, the additional beds in the paper, we have submitted a pre-application planning statement for a multi-storey car park to help recreate that patient parking. And we're also developing a package of measures to help alleviate traffic congestion, manage the demand for parking and to promote sustainable travel. And we're working really closely with Portsmouth City Council and the University of Portsmouth on that sustainability challenge to make sure that we have that front and centre in terms of our designs. So today I think we're bringing this here as an update in terms of where we are with the programme and a commitment to come back to the committee at a convenient point for you to make sure that you're cited on the developments as they progress or as you require.
Thank you, Penny, for that clear update. Very useful indeed. And I really do hope that this project, when it comes to fruition, is going to solve the vast majority of the ED problems that QA experiences that we all know about, and we wish you well for that. Do we have any questions from members for Penny? I'm scanning the list. I don't see a single hand, so I think we conclude, Penny, that you've answered all the questions anyway. So thank you very much indeed. We can go to the recommendations. There are two. One is to note the update, which we already have, and the second one is to ask if you would come and give us another update in the summer of next year. Hopefully, it can be a physical update and not a virtual one. Are we agreed?
Agreed.
We are agreed. So thank you, Penny, very much for your input this morning, and we can now move on to the next item.
Thank you.
Thank you. So item 7, issues relating to the planning, provision and/or operation of health services. So what we have now is an item on the NHS 111 First programme, and we have with us again Penny to talk us through this, along with Sam Chapman, who is from the Southeastern Hampshire CCG, and Mark Rowell, who I noticed just joined the meeting from South Central Ambulance Service NHS Trust. So Penny, again, are you going to lead on the start for this one?
I think Sam's leading the presentation. I'm very happy to bring in additional detail on Portsmouth, South East Hampshire if questions arise about that.
Okay, Sam, are you happy to take us through it?
Yes, of course. So just by way of introduction, so although my email says South Eastern Hampshire CCG, my actual job title is I'm the Associate Director of the Urgent and Emergency Care Programme for Hampshire and Isle of Wight STP. So my remit and portfolio covers a much wider patch than just a portion of Hampshire.
Sam, thank you for that clarification.
That's okay. It's anyway. I'll carry on. So if I talk to you about 111 First, and there is a very comprehensive paper that has been submitted, which goes through a lot of the detail, which I won't cover off all of it. But 111 First, in its essence, is root. Was a program designed to react to the way that our general population accessed healthcare in light of the COVID pandemic wave 1, which started back in February and March of this year. And what we saw across the country is that the numbers were extraordinary, but a 5-fold increase in NHS 111 activity, where patients made a very distinctive move from accessing it face to face to going to our 111 services first, and that caused a number of operational problems. It was we've got Mark Rowell from SCAS on the line, which I'll bring in shortly, but SCAS performed very admirably in actually stepping up and providing national contingency for a number of 111 services that I'm sure you can detail. But the aim of the programme, which was launched throughout the summer, was to capitalise on patients that had moved from physical accessing of healthcare to see whether we could bolster and change the way that patient behaves in accessing and being able to direct them to the right place first time. And to do that, there's some of the physical aspects that have been put in place in Portsmouth, which are very useful and innovative. But the large majority of the project is bolstering our telephony services and providing a 24/7 clinical advice service from GPs that sits behind a 111 call. So the patient will go and speak to 111 And then if they have a disposition of ED before they go, they will be put through to a GP who will be able to do a senior clinical assessment and be able to advise that patient if indeed ED is the right place to go, for which they can get a booking, or they can be booked into their primary care services, or they can be booked into a myriad of other services that we're bringing online as we go through. Portsmouth was selected as a fast follower, and I'll ask Penny just to talk through the nuance about what's slightly different about their pilot, but everywhere else is due to be live by the middle of December. So our North and Mid patch, which is the area surrounding Hampshire hospitals, went live with their soft launch 3 weeks ago. Isle of Wight is due any day to go live, and Southampton and South West system are due to go live on the 25th of November. All of which, all of our systems now have progressed through our regional NHS England assurance, and so that we're very happy, and NHS England are happy that the models that we're proposing are safe for patients. If I just bring in Mark just to cover off some of the differences and with SCAS, and then come to Penny about Portsmouth.
Yes, so as Sam said, we have rolled out the whole system, the 111 first. From a SCAS point of view, clearly we needed to, that's around a 20% additional demand. So we have had to put in place a large recruitment plan which started in September, and we've increased our recruitment plan to day courses and evening courses, because that 20% was a significant gap to cover. So we've done that and worked very well then getting clinical resource in as well. And as Sam said, most of this is being led certainly within the Hampshire footprint by GPs, clinically revalidating patients who reach an emergency care disposition or reach a lower acuity ambulance disposition. So that's our CAT 3-4s, which from a 999 perspective, that's 120 minutes to get to. So within that time, we get to those patients within half an hour, bring those patients back, and we can then signpost them appropriately. Trial is very successful. What we are seeing is a good 50 to 60% of patients being redirected away from ED and for the CAT 3-4 validation. So the results are really quite encouraging and quite powerful. And each of the hospitals has a booking system in place electronically, so they know those patients are coming. They can see the clinical information around the demographics and the clinical outcomes of those patients, for those then who are booked slots within the relevant ED departments. So we do have GPs on our 111 clinicians all on the same operating system, which again is quite powerful, that we can then, as it settles down, share that resource across the Hampshire and the Isle of Wight patch.
Penny, do you want to just touch on the nuance of the Portsmouth model?
Yeah, of course, thank you. So Portsmouth was the first system to go live nationally as a early mover. So at the end of June, we put in place the model that's been described for any patient who was already accessing urgent care through 111. So the premise of what we were trying to do was broader than just booking patients into the emergency department. It was about saying across the emergency system, so all of the different areas where you could access emergency care in Portsmouth, South East Hampshire, whether that be a pharmacy, general practice, an urgent treatment centre, somewhere else inside the hospital or our emergency department. How did we make sure that we were getting our patients to the best place to suit their needs? So what we put in place from the end of June was that any patient who was already calling 111 would go through the system that Sam has described. So if 111 determined that they might need the emergency department, they would then go through the clinical assessment service with a GP who had access to their clinical notes to then say, does this patient definitely need to be booked into the emergency department to be seen by emergency care clinicians, in which case they would be booked in, or is there an alternative place where they could go? So we tested that model for nearly 3 months actually, and we're informing the national specification as part of it, because the national rollout that Sam has described was being developed in parallel with our early implementer site. And then we made a further change at the end of September. So during that initial phase, we tested whether we could use that same system for patients who choose to attend the emergency department without having first rung 111. So if you come to our emergency department now, you'll see that we've got a new entrance which has got a bank of 6, I think, iPads and a telephone, where you would be able to, as a patient, so you would arrive at the emergency department, you'd be asked whether you have a booked appointment, in which case you would come in. You would be asked a series of questions to check whether you have what we call any of the red flag indicators, which means that you're an emergency and therefore you must come straight in. If neither of those things are true, then you would be supported to access 111 online through the iPads to determine whether the emergency department is indeed the right place for you to receive your treatment, or whether your needs could be better met through another service. We have in place members of staff who are supporting people to use that technology. So if people are not familiar or not comfortable with that, we've got a member of staff on hand, either to help them navigate through or to help work out what does that mean in terms of the outcome from the iPad. So we've been running that since the end of September, and that's the piece that's slightly different in Portsmouth, South East Hampshire, that we've been testing whether the 111 online system can be used in that way for all emergency patients, rather than just those who are already choosing to access 111 before they come to site.
So I think it's I mean, it's a fantastic coup for us in Hampshire and Isle of Wight to have the pilot site in one of our trusts. So it's been brilliant to have that happening in Portsmouth. I can speak for the other trusts in saying that they're very, very keen to adopt at the earliest possibility Portsmouth's model. But we have to NHS England have to complete their evaluations and etc. And we're going to play a key part in that, being able to directly compare and contrast 2 different models within Hampshire and Isle of Wight. So we're hoping to play into that agenda. 2 other things that by way of update, which I think should be noted. The first is for paediatric patients. The majority of our pilots at the moment don't cater for paediatric patients. And we're doing a final piece of work to put online a paediatric clinical assessment service to fill that gap. So that's following hot on the heels of our adults, but is in development. And the second one is that we're doing a bit more work. Now we've got the pilot, which is fantastic for the vast majority of patients. We recognise that there is an inequalities agenda here, and there is a number of our population in digital poverty, etc., that this service will not be appropriate for, and we have to assess further alternatives and to make sure that we're not inadvertently disadvantaging cohorts of our population. So that work is also underway over and above the assessments that we've already made.
Muted.
Yes, I'm back online again now. You probably saw a kerfuffle earlier on. My laptop was running out of power. I hadn't checked that the plug was in properly, but I managed to save it before it all died. It would have been a disaster. Right, here we go. Thank you for your exposition on NHS 111 this morning. Obviously, the improvements you're going to gain from this are immense, I suspect. Can I just be clear about the use of iPads actually in ED? Were you using them to see whether patients could make use of them, and therefore that can be the model, as it were, out with the ED? Or were you actually using it to do the diagnosis? Because it seems to me, why not have a cell of 111 people in ED who do it straight away?
Yeah, so thank you. The iPads aren't being used to do the clinical assessment. They're being used to do the same decision making that would happen if you were sitting on your sofa at home, either on your own iPad or on a telephone. And actually the feedback that we've had from a number of patients is, if I'd known I could do this, I would have preferred to do it from my home. So there's a really important message for us that says those iPads really should become a bit of a fail-safe, that if somebody hasn't already done that from their home, they are available there for them to use. And of course, a patient could use their own iPhone in their pocket or their own smartphone to be able to do that. So it's not a clinical assessment. It's absolutely before people come into the emergency department. It's a decision-making tool to say, is this the best place to meet this patient's needs?
Okay. Question from Councillor Keast.
Thank you, Chairman. I've actually had calls to use the Portsmouth system, and I have to say it worked like clockwork. I rang in and was assessed, and I was sent to St Mary's walk-in unit. And I was back home again within an hour and a half total time, and it diverted me away from QA, from the accident department, which is what you want to do. And I thought it was actually worked perfectly. So congratulations, it really is a good system.
That's really good to hear. Thank you.
Yes, thank you, Councillor Keys, for giving us an example. It wasn't clockwork, it was digital. Any more questions?
And I think just to follow up on Penny's smart row here, sorry, just to follow up on that obviously once the patients who use the booths, once they've completed the assessment, are then referred on to the GPs, and the GPs do phone them back and then can signpost those patients appropriately. And if required, yes, then we will give them an appointment. But actually the GPs are signposting those patients to St Mary's or to other services. We're able to book patients' appointments via this system as well. So using GP Connect, we're able to book patients' appointments either into their own GP or then into an out-of-hours service. So that bit's quite powerful. And certainly with the call handlers, when they're taking the call, what they are able to do is refer patients to an MRU or a UTC. So obviously Councillor Keith's experience was probably call handler, got to the MRU, I'm now going to book you an appointment, which is really, really powerful.
Yes, it does sound really good. Councillor Carew, you have a question.
Thank you, Chairman. Question for Penny. Penny, iPads on arrival to A&E, unless they're accompanied, less patients are accompanied, I would have thought most patients who turn up to emergency departments are by their very nature not in a very fit state to answer a series of questions. The second issue I have is the reason that there has been an increased use of ED in A&E departments nationally. I think I'm right in saying that it's because patients can't get GP appointments and are having operation appointments operations and hospital appointments cancelled due to COVID-19. So in desperation, patients are going to A&E departments to try and get a diagnosis or some action. We know there's a national shortage of GPs, and 101 is clearly part of the answer, but isn't also early interception at GP level, where walking services are not available, something that needs to be looked at in terms of taking people out of the system if they shouldn't be an emergency department in the first place?
Okay, so I'm probably not the best person to answer the question around the levels of general practice that we have in the patch, but what I can do is answer your query about how are we using general practice in this model, and then what have we seen in terms of attendances and impact from this. So one of the really powerful things about this model is the involvement of general practice. So we can see the impact of getting patients to the right place, of having not only a GP rather than a different clinical call handler. So a general practitioner has a broader scope of practice and therefore is able to take a broader range of decisions about where an individual could go. So that's the first benefit that we see. The second benefit is that they have access to that patient's record, and therefore what that means is we can potentially avoid having patients who might have a series of long-term conditions and appointments in other services having to experience emergency care, and we might be better able to route them back to the services that are already addressing the combination of needs that that patient has. So that's a real benefit, that we're trying to make sure that emergency care isn't the only answer for patients, and the fact that we're able to book appointments back into primary care through the system is a real benefit. So I think it does keep general practice as a core part of the success of the model. So that's the first piece. The second bit in terms of attendances, so we have seen a correlation. We can't say it's a direct cause and effect, but we have definitely seen a correlation between our communications activity around 111 and a change in attendances to the emergency department. So we have definitely seen that, and it means that we are able to perhaps treat some of those conditions that might ultimately present in an emergency in a more predictable way. So I do think it's part of addressing some of the challenges that you've quite rightly outlined in your question.
I think just to add a couple of bits, from a Hampshire Isle of Wight perspective, we've seen a lot of these miners' attendances are down and suppressed across the patch. So we're trying to understand at the moment how people are accessing healthcare, and we think that for minor illness and injury, people are staying away from our accident emergency departments, but perhaps presenting a little bit later on and with more serious conditions, because we've seen a case mix across Hampshire Isle of Wight change a little bit more severe. And the other thing that I think, which is a really useful part of that query around access to primary care, is that not an insignificant number of these calls are diverted or the patients are directed to pharmacies. And so patients accessing and going through this triage quite often are not being given a primary care disposition, but in fact, for repeat prescriptions, for medication issues, are being directed to pharmacies as well. So whilst there's a number of patients that are moved from ED to primary care, there's also those primary care patients that are then moved down to pharmacy. So there's all sorts of different bits and pieces at play, but all quite useful.
Thank you, Sam. I mean, the message there is that if people perceive that they have a medical problem, it's best they tell someone about it and get it sorted out. A stitch in time saves 9. Councillor Harrison, you have a question.
Thank you, Chairman. I mean, I welcome this. It looks like a very attractive project. I'd be particularly interested to see in 12 months' time some information about how it's worked. And I just wonder whether you have in tandem with this a process for picking up complaints and indeed praises for what's happened, so that the Scrutiny Committee could gauge just how successful or otherwise it's been.
Oh, no, go on, you go.
So absolutely. Although the pilots are relatively, Portsmouth has been going a little bit longer than others, we are picking up a mechanism by which we can measure that activity across Hampshire Isle of Wight, which is the first point. So we'll be able to directly compare and contrast, find out where these patients are going. And for the first time, and I think this is the important thing about 111 First, is that we have an end-to-end governance process. So up until this point, if 111 disposition was go to an ED, we'd send the patient to ED, but we weren't tracking whether they turned up to ED. This, by way of making appointments and tracking the patient all the way through, has enabled us for the first time to pick up patients that haven't turned up to ED, and put in the relevant safety checks to make sure that those patients are well and okay and have either sought medical attention elsewhere or no longer require it, or for a number of myriad of different reasons why they might not attend. And the second part, which is about the patient feedback, absolutely all of those patient feedback loop is being, we're doing interviews, etc. I'll ask Penny just to do the Portsmouth bit because they're more advanced than the rest of them, but just to be assured that all of our systems have got patient feedback as a key component of their rollout. Penny.
Thanks, Sam. So just to say, there is also a national evaluation running, which allows us to look outside of Hampshire and Isle of Wight, and it's focused on the few early implementers, so those of us who went first. So that will be useful to see how we compare to other parts of the country as well. But in terms of the patient feedback, it's been an active part of our approach to implementation. So how are we checking whether patients are getting an improved experience from this? And that was where we got the feedback that I referred to earlier, that actually people would have preferred to have known more sooner to enable them to make a different choice. We've had surprisingly little pushback actually to the model, and the majority of the feedback has been really positive in terms of how it supports people to access the right services in the right way, as opposed to potentially using the emergency department as the default because they don't know where else to go. The value of 111 is that they know all of the options in our local health economy, and they can make a judgment about the right place for that individual. So it effectively gives you one point of access to a whole range of services, and that's the feedback that we've had from patients. But we'll continue to gather that as we go.
Brilliant, thank you.
Thank you both. I don't see anyone else indicating a question, so thank you, Penny and Sam and Mark, for your input to this part of the agenda. Clearly, it's a massive improvement, and I think I heard you say earlier, Sam, that there'd been a 5-fold increase in 111 calls during the COVID crisis, let's call it that. That might be an explanation for an incident that we reported at our last HASC. One of our members had a rather difficult time overnight with the 111 service, so we're investigating that separately. But it could well be that the 5-fold factor might have been a factor.
I should add, just for clarity, that was only during the wave 1 pandemic, so it was for a couple of months, and then it's calmed down again as the
right. Okay.
It directly correlates to COVID outbreak.
But is it currently at an elevated level?
I think Mark can probably talk to that.
Yeah, so we are seeing those pressures in hours. So during the primary care in hours bit, we've seen our demand is up by 30% compared to this time last year. So it is having an impact on 111 call answer and our performance, which is why we've got this heavily recruitment plan in place. So we have done the modelling around obviously what Think 111 First was going to give us as additional demand, plus what we are currently seeing, which is why we're in the middle of a heavy recruitment plan.
Thank you. Thank you. So members, we can go to the recommendations now. The first one, of course, is to note the reports that we've had this morning. Are we happy to do that? No dissensions, good. And then the second recommendation is to ask if you would like to come and give us an update on this matter in the summer of next year. We think that's a reasonable time for it to be bedded down and seen to be under metrics that you've described, Sam. Is that acceptable?
Agreed.
Are you happy with that, Penny, Sam and Mark, about coming back in the summer?
Absolutely.
Yes.
Please.
Thank you very much indeed.
They did nod their heads, Chairman.
Sorry?
They did nod their heads before.
Good.
So did you.
Right. We can now move on to the next item. We're looking at various COVID reports now. Now, what I'd like to do, we're looking at items 8, 9 and 10. They're all COVID related, and I'd like to do what we did last time and ask the presenters to go through their different sections, and then we'll have questions at the end, because often there's a lot of cross-cutting of areas. So do make notes of questions as we go through the presentations, and then we'll have a Q&A session at the end. So the first presentation it will be on public health, and I hope, yes, it's time. Simon Bryant, who is Director of Public Health, Hampshire County Council. Simon, are you there?
I am indeed. Councillor Huckstep.
Welcome. Good morning. Would you like to kick off then with the first COVID update?
That would be fantastic. Would it be okay if I shared a presentation?
Yes, please.
So bear with me while the machine wakes up. There we go. Can you see that?
Not yet.
Yes, you're there.
Yes, it's up.
Great, thank you very much. Apologies, as you know, things are moving fast. This was updated last night, so some of the data is moving forward. So apologies, you haven't had it in your packs previously. I can work with Marie to get that sent round. I'll just talk through some of the data and some of the updates regarding COVID. So this presentation gives input on cases and deaths and hospital admissions, and then I thought I'd update a little bit on testing and a little bit on the new national restrictions, just so we're clear kind of how that's working. Again, though, happy to take any questions afterwards. So, excuse me. So we can see the pandemic epidemic curve that you're used to, and we can see that we've got this increase on the right-hand side of cases, and the line has disappeared from last time, but the 14th of July was when we increased pillar 2. So pillar 1 was just hospital testing. On the right-hand side, we've seen an increase. And I can say in the last 7 days in Hampshire, we've had 1,737 cases. So you can see, and that's an increase on the previous 7 days. And our rate, which is really important to understand because that helps us to compare to the rest of the country, is 125.6 per 100,000 for the last 7 days. That compares to England of a rate of 243. So when we look at the different districts, you can see, and I think there was a question last time trying to make the lines a bit clearer. I hope that's helped. And also you've got the table there. So you can see that what you've got there, the dark black line is England, and you've got different rates for our different districts, and the kind of red one at the top is Rushmore, bearing in mind that Rushmore had an increase in cases in the first wave, and I've got a slide in a minute that looks at the last 7 days. Each district and area has gone up. You can see this one at the bottom is the Isle of Wight, obviously less relevant for this meeting, but you can see that the cases are going up. When you look at the weekly rates, you can see the rates there across our districts. Our 7-day rate, that's the one I just gave you for Hampshire at 125, and you can see variation. But as you look through different weeks and different timescales, you see that the different districts may go higher up that scale or further down because of the smaller numbers in the district. So it's just really important to understand that, but that gives you that district rate. And you can see there, particularly thinking about, we were concerned about Rushmore earlier on in the second wave, and it's very much in that centre of the pack there in terms of number of cases and rates. But equally, we're concerned about all areas. So as we think about the pandemic, actually working at district by district isn't the most helpful approach. It's best if we work as a county to further reduce spread, and I'll talk about some of the actions and how that's going to work in the future. So this is the number of cases per 100,000 across England through the week. So you can see on the left-hand side, excuse me, week 43, and on the right-hand side, the next week. So you can see that kind of red area increasing and the orange area increasing. You can see the spread throughout the country and how that's going up and rather than down, which is what we'd like, which is if we think about why we've got new national restrictions, with those dark red areas increasing, the red areas and the orange areas, we need to really think about the restrictions that are needed to prevent spread. And then if you look at patients in hospital, you can see across the country, I like the way my team have done some different colours there, but you can see the southeast and the pink on the bottom right showing an increase, but they all follow the same kind of trend. And we've seen some of the news pictures around the northwest, and I think it was Derby last night was on the news. So you can see that different areas are a little bit ahead of us in terms of how they're being impacted by COVID. And then this is mechanical ventilation, equally very important. Again, much lower, but you can see that's on the increase. So those are the people requiring ventilator beds. And you can see on the 7th of November, that was 44 in the southeast region. And then really important to look at deaths, because we know that sadly, COVID does increase deaths. I've presented this graph before, remembering that the peak in the middle, the kind of burgundy parts of the deaths from COVID, and the other ones are deaths from other things. And the green line is the 5-year average deaths. So excess deaths are above that line, and non-excess deaths, as it were, are below. And you can see this last recorded week, we've had 8 COVID deaths, but still below the excess death rate in total. So we need to look at that over a longer period of time. And then we've got, sorry, I slipped in, cases in the UK. You can just see that's following that same pattern of graph. So the national testing strategy, I thought it was just worth updating because last Saturday the Prime Minister made an announcement about testing. Useful to know what that is. So just for a reminder, there's Pillar 1, which is the hospital testing and the kind of the previous lab capacity we had. Pillar 2 is the new lab capacity we have. So that's all the testing sites, and I've got a slide showing all of the new sites we have. Pillar 3 is for antibody to see if people have had the test. Not helpful in one sense for managing the pandemic, because actually we don't know if it provides long-term immunity, but still it's helpful to understand where people are and how that's working. And finally, Pillar 4 is the surveillance. So that's when we look at trends using the Office for National Statistics to see where the pandemic is going. And that's really how nationally they look at it and see what actions they need to take. So we use that as surveillance. This slide really shows you the range of testing modalities that we have across the whole of Hampshire and Isle of Wight, Southampton and Portsmouth. We have a regional testing site that's in Southampton Airport, and that's the drive-through. We have mobile testing units that are parked in different places around the patch, and they move around. We've got 9 local testing sites, and that's increasing, and those are the walk-in sites. For Hampshire, we have 1 in Gosport, 1 in Fareham, 1 in Basingstoke, 1 in Winchester, and 1 in Aldershot, and we're setting up 3 more. So we'll see much more walk-in sites. For vulnerable adults, we have a care home programme, and we have weekly testing in care homes and monthly testing for care home residents. And we have testing for more vulnerable settings such as supported housing. Each school setting has their own kits that they can use if need be to manage outbreaks and test people who can't get tests. And should there be an outbreak, we can use the community testing service that we work in partnership with our CCG colleagues. So we're saying all these testing modalities are run by the Department of Health and Social Care, and we're kind of the logistics arm locally, making it work and overseeing that. And then there's a number of pilot programs that we are looking at. We've got the University of Southampton salivary test. We've got the lateral flow test, which was announced last week by the government. And all these are different approaches we can use locally. So the salivary testing is obviously simple to use, slightly less invasive, not a swab up the nostril and down the throat, and could be used for some kind of mass testing program. So we're looking at how that could work. The lateral flow test is a 20-minute test. However, it's not as sensitive as some of the PCR tests, so the test we do normally. So if someone has one of those and tests positive, they still need to have another test to make sure that they do have it. But it's really helpful for us to understand that. So it's like a screen when you go for some kind of other screening program, like a bowel cancer screening or a breast cancer screening. It doesn't say you've got it, it's a screen. And then there's other things like the LAMPOR test and the VAN lab. So we're looking at all of those options for us locally. So a number of pilot programs which will really help us to understand the state of the disease and manage outbreaks. So just finally, I thought I would talk about the national tiers. So there's 3 national tiers, as you're aware, that we're looking at different indicators here. So the 7-day rate, in over 60s, which is an important rate because we know those people are more likely to be hospitalised, test positivity, and then other relevant indicators. And that's where we were before we went into the national restrictions. So we are looking at these and working with government to understand what we should be looking at in order to come out and make sure that the rules and the guidance for different tiers are really clear, because at the minute there's slight variation before we went into national lockdown, what you could do in Liverpool to what you could do in, say, Manchester. And actually that's not that helpful for people to understand what behaviours they should be following. I think just at this point it's really worth me saying, as we go into national lockdown, the numbers are rising across the UK, and that's the same in Hampshire, as you see, and that's really important. We need to do all we can to prevent the spread of this virus. So we need to do our social distancing, we need people to stay at home, we need people to do good hand hygiene and wear a face covering where required. And during the national lockdown period of the 5th of November to the 2nd of December, we also require people to stay at home, to prevent gathering people who you do not live with, and for certain businesses to close. So you can see we're in a place there. We need to use this period of time to really make sure we make the best of it, because it's not, I absolutely appreciate the economy and people's mental health and well-being. It's really not perhaps what we'd like to see. However, it is really essential for the preventing the virus spreading. So if we can use this really effectively and all play our part, we could see the virus stabilise and come down. Councillor Huckstep, I'll stop there and then listen to other presentations and take questions afterwards.
Thank you, Simon. So now we have Graham Allen, who is Director of Health and Adult Care. Graham, are you there?
I am indeed. Thank you, Chairman. I'm just going to put up a slideshow if that's okay. Let me see if I can just find the correct one. I'm going to hand over initially to my colleague Jess Hutchinson, and Jess will talk us through the first part of the presentation, and I will then give an update around care homes. So hopefully the presentation is just loading now.
Yes. Good morning, Jess. Yes, it is up. Also, this presentation is available on our ModGov iPads, I believe.
It is indeed. It's already been uploaded, but we'll talk through the presentation. Thank you. Jess, over to you.
Thank you, Graham. Good morning. Adults Health and Care, as you will have already established, needed to move into response as a result of the second lockdown. We've stood up our emergency structure, but we were already well prepared and have moved our preparations into action. That we're continuing to monitor closely our Care Act duties and are keeping a strong eye on recovery throughout the response, the new response phase. With regard to our welfare response, the team was stood up on the 5th of November, and already we have contacted 25,000 residents as of today, and 9.6 thousand residents have contacted us back, and 7.4 thousand have said we're fine, thank you, we don't need any help. And so this is with regard to the clinically extremely vulnerable people in Hampshire. There has been significant change to the clinically extremely vulnerable group and the guidelines around them as a result of government work. And the government have moved away from calling this group a shielded group. They're encouraging them people to go outside, but at the same time are saying to them very strongly not to enter shops or pharmacies. Although that's only advice, obviously lots of people want to take that advice from the government and act upon it. Indeed, as well as those 52,000 people, we have the wider group of vulnerable people in Hampshire, so that group over 60 who are also at increased risk. And I'm pleased to say that our helpline, which has been rebranded the Hampshire Coronavirus Support Helpline, is operating now 7 days a week and is supporting that group of vulnerable people as well. So one of the functions that the local authority in collaboration with districts has had to take on is re-registration and supporting people to re-register if they can't manage that themselves and yet they want to be a registered member of the CEV group. We've been using an automated call service that we established within Wave 1 to make sure that we manage the volume as efficiently, effectively and as timely as possible, and that has been working well. We've also been continuing with a large-scale communication campaign to help clinically extremely vulnerable people become more digitally enabled. You may have seen Getting Granny Online is one of those campaign strap lines. We're continuing to take a multi-agency approach across all of our work, so working into care homes in tandem with the NHS, and obviously working closely with the acute hospitals. We are working closely with districts and borough councils with regard to our welfare offer, and of course our key partner, the voluntary sector organisations across Hampshire, have been supporting us to do a fantastic job. We're also we are aware that in our local response centres we've already had 170 referrals for volunteer support, and all of our volunteers are showing sufficient capacity at the moment and are working well with us. We're still providing phone support through the CAB and local mind organisations for those people who might have financial hardship or mental health issues as a result of COVID, and working very closely with our fantastic carers organisations, Andovermind and Princess Royal Trust for Carers, as well as other organisations. I just wanted to say a word around day services. This is an area where we're working hard to balance the need for respite for families with that increased infection risk, and that is playing out for us in slightly different ways across different care groups. Unsurprisingly, because of our older adults' additional vulnerability through age, we're finding that the majority of the older adults day services are actually suspended currently, although we are continuing to provide for people who are risk assessed as really needing services to prevent family breakdown. But we're looking at that on a balance and working hard and ensuring infection control is paramount there. But we are keeping the remainder of those people who've returned with learning disabilities to day services in day services, although we have reduced that offer to those who absolutely need it most, and are also making sure that we take the right infection control steps in those situations too. HCC care services, is important to say, remain open, and where people can't access a day service, we are providing outreach alternatives as appropriate. We're working closely with all of the providers involved in this work, not only on outbreak control planning, but also on our recovery, and through close contact with our commissioning department. So I think one of the services that might might require specific mention is that Age Concern Hampshire is a service that's closed, however, are continuing to offer home visits and outreach. I think, well, despite the fact that we have moved into lockdown and have initiated response, we have to keep an eye to the medium and longer term. And clearly a further period of response tends to place more financial pressure on any organisation and on all organisations. So we do need to keep our mind on transformation to 2019 and 2021, the savings programmes there, and working hard to continue to focus upon that. We are continuing to put staff wellbeing high up on our agenda and are reinitiating a wellbeing support hub. In fact, I've just come from an operational managers meeting where we're making that offer available to staff and advertising that widely. Also, we're keeping a close eye through repetitions of employee surveys. And we have another survey open in the near future. We've just closed one survey and looking at the results of that and learning from that. And in all of this work, we're continuing to take a continuous improvement approach and learn lessons across the organisation. And that's overseen by the Care Governance Board and Graham Allen, the Director of Adults Health and Care. Thank you.
Thank you, Jess. So, members, if I just move us on to an update in terms of care homes. So, firstly, I wanted to draw your attention. I'm sure you will have seen, but Department of Health and Social Care published on the 4th, so the day before we went into the new national restrictions, some updated guidance on care home visiting. The details on the slide are taken from the published guidance. I won't dwell on this. Hopefully you will have had a chance to see it in the slide deck that was uploaded onto ModGov, but clearly the message is, and we absolutely understand and appreciate the importance for those people living in care home settings to feel connected and to have links to relatives and others. And certainly it was one of the consequences of the initial lockdown that we saw in the spring and the summer, in terms of consequences for residents within care home settings, in terms of them becoming closed environments and the impacts on mental health and indeed other physical manifestations of that. What I would say is that the new guidance, whilst gratefully received, it also provides some challenges to providers in terms of continuing to maintain safety for residents and indeed staff. And there is work ongoing by ourselves with CCG NHS partners to support the wider care sector, the care home sector in particular, in terms of ensuring that safety for residents and staff could be maintained. I would also say at this point that very positively we saw through the spring and the summer and subsequently new ways of maintaining contact between residents and relatives being available. So through new technologies in terms of web and video conferencing facilities. Very positively, members, we've been able to successfully bid for some additional iPads from NHSX, which is the national body, part of the wider NHS England. And we are in the process of taking delivery of a further 360 or so iPads that will be dispensed out to care homes where they may at this moment in time not have sufficient device capability for all of their residents for video calling. So really, really positive development just in terms of enabling people to remain connected with loved ones. This next slide, members, this is a dashboard that we've developed and we've been using within the department over the last 6 months or so. I thought it might be useful just to share with you today. So from the National Care Tracker that was initiated back in around about May time. So every care home in England was expected and encouraged to start submitting on a regular basis, at least weekly, information to the Department of Health and Social Care in terms of giving greater insight as to what has been taking place across the care home sector in England. We received that information, so NCT, you'll see the abbreviation NCT on this slide, is National Care Tracker. And to that, we've added more localized data to provide us with this summary page. It enables us to dive into extreme detail, care home by care home, and indeed there's a corresponding version of this for the domiciliary care sector as well, but I thought it would be useful for you to see the care home tracker that we're developing. And the different areas on this summary slide have changed over time. And what we tend to do is, as different issues may come higher up the agenda in terms of risk or priority, we've included them and then we've taken some additional information off. So if I go back to the spring and the summer when we initiated this, one of the areas of extreme interest on a daily and weekly basis was around the availability of PPE. What we've seen is a huge amount of progress made in terms of the availability of PPE to the sector. So actually we don't include that update on this summary slide. It's contained within the detail that we've got, but we've ended up currently with these 8 key areas, and we keep a very close track of this. One of the things that I would say from this data, you will see in terms of homes updating their submissions and their data to the National Care Tracker in the last 7 days is at 84%. So 400 of the 476 care homes that we have across the county of Hampshire. Of course, we don't go, oh, we could do better, and then see what happens the next week. The teams that are working together across both Adults Health and Care and our CCG NHS partners are then in active contact with those 76 homes that haven't updated within the last 7 days. And indeed, through our drill down, we're able to pick up any particular issues that individual care home providers may be flagging, not only through the National Care Tracker, but through the additional insights that we have locally. You'll see on this slide at the bottom on the right hand side that currently just under 7% of care homes in Hampshire have got positive COVID cases, and that relates to 78 residents, and there will also be staff self-isolating as a consequence of either a positive test or concern whilst they await a test result. And on the left-hand side, and I'll speak to the issue of vaccination in a moment or two, but just to be really clear, we're really interested in seeing the uptake of seasonal flu vaccination across the care home population. And at this moment in time, around about 5,000 care home residents, so give or take just over 40% of those people living in care home settings have at this point received a seasonal flu vaccination. It's really important that we keep that under close scrutiny. Seasonal flu is a key issue for us, clearly, given the time of year. And we also know that there is a double risk in terms of seasonal flu and COVID. So increasing seasonal flu vaccination is really, really important. In terms of deaths, and Simon referred to excess deaths earlier in his presentation, this is the latest update, members, of a slide that you will have seen previously from me. So in terms of the detail here, between the 28th of February and the 23rd of October, there have been 2,906 deaths in care homes across Hampshire. And of that number, approximately 800, and that's the number I gave at the previous HASC update on care home situation, approximately 800 of those deaths are deemed to be excess. We again keep that under close scrutiny, but very positively, since the summer, we've seen a reduced number of care home deaths week on week. In terms then of concluding from my perspective, hopefully you'll have gathered from the summary of the dashboard that I've shown that we continue to view the sector with extreme scrutiny, and we're clearly keen on providing as much support as we possibly can, but we're also very cognizant of potential risk or failure within the sector. And that may be for a number of different reasons, including occupancy levels, it may be to do with staffing levels, it may be to do with admissions. Particularly important at this time of year because we know that the sector will be under increasing pressure. It's a natural pressure this time each and every year, but of course that's heightened because of the ongoing challenge and risk of COVID. There's a huge amount of work continuing to be done, again, across ourselves and partner agencies, predominantly ourselves and the NHS, around infection prevention support. And there is a wide range of support available, and that includes testing. And Simon, again, in his presentation, gave an update in terms of testing strategies. I'm pleased to say that care homes are very receptive to the support offer that's been made available to them for now more than 6 months, and there are dedicated teams working with care home providers and indeed the wider sector. In terms of financial support, we've successfully deployed 7.8 million of new government funding by the end of October, and a further tranche of 7.8 million is due to be made available again to the sector in mid-December. We're monitoring, as we're required to now on a monthly basis, the utilisation of that financial support that's being provided that's come to us from government. Just wanted to say a few words on vaccination, although others are more qualified to speak of the news that was given yesterday, which is indeed very, very positive around advances in terms of COVID vaccination possibilities. I do want to say that clearly, whilst the news is extremely positive, two key things. It's really, really positive that in the Prime Minister's press conference yesterday afternoon, that priority was identified for care home and care sector clients and also care sector staff. Absolutely vital. I think the thing, though, alongside that is a degree of caution, because a vaccination program of this kind, subject to certification and the availability of a COVID vaccination, will be one of the most challenging logistic issues that many of us will have ever faced. So the word that's often been used within response to COVID is unprecedented. So we now find ourselves in terms of a vaccination program really, really positive. But again, it will be an unprecedented logistical challenge in terms of making sure that that can be rolled out to our population in an appropriate way. And then finally, members, just to say, clearly, given the current national restrictions and the care home visiting guidance, that we are very, very focused on the risks of isolation for residents and the challenges to staffing levels as we go forward. Some of that can be ameliorated and mitigated through the use of new technologies, but clearly it remains vitally important for relatives, friends and others continue to be able to support their loved ones in care home and other settings. Thank you. I will stop presenting at that point.
Thank you, Simon. Thank you, Graham. Thank you, Jess. Now we can move on to the presentation by our NHS colleagues, and they're covering Southampton, Portsmouth and the Solent areas. And we've got Dr. Andrew Bishop with us again from, recall he was with us last time, and Ruth Coburn-Jackson, who's addressed us earlier. Andrew, Ruth, how do you wish to play this? One of you going to kick off and then the other, and then we can have a Q&A addressing all of the COVID reports we've heard to date.
So, Councillor Huxley, shall I take that, and then Ruth will tell me when I go wrong. Yes, just by way of preamble, and just to reflect on having heard from Graham and from Simon, I do think we would want to say from health what a particular asset our care home sector is in Hampshire, and not only the scale of it, but the flexibility in the way it's working, and how vital it is for health that we work together. And Graham and the team have really meant that this is working so much better than it ever has before. But it's a particular asset to us, and we work very closely with them. You have a paper of an update, and I'm not going to project it. But I thought I'd give you an update, first of all, about just where we are with COVID, and then secondly, briefly, how that reflects on the rest of what's happening in health and social care, in healthcare. The difference between this wave and last wave, and Simon will have shown you this, is although there's a large number of people who we now are infected with the COVID virus, by virtue of the fact that the testing is so much more developed, and also that there's a large amount of that which is in the younger population, we aren't yet seeing in health the same amount of activity specifically from COVID that we did before, and whether that's in primary care, community care, or in the hospitals. While we're now seeing significant amounts of illness associated with COVID, it's not at the scale that we had before. Primary care is still benefiting from the way that they've the GPs learned really to maximise the potential for virtual consultation and triage, and are still in good shape. And our hospitals, while they are seeing increasing amounts of COVID every day now, it's nowhere near the level of COVID that we had before. Just to give you a feel for that, we have about between 3,000 and 4,000 hospital beds in Hampshire and the Isle of Wight. And at the moment, there's about 350 patients in those beds who are suffering with COVID. And we have about 100 or between 100 and 150 intensive care beds. And the number of patients on ventilators due to COVID, while it's important and growing, is about 15 or 16 at the moment. So you can see that if all we had to do was COVID, we would be well within our capacity. But it would be misleading to suggest that that was not on the increase, and that is a significant increase from this time last week and a significant increase from this time last month. The issue, of course, is that that's not the only thing that's going on in the health service, and particularly in our hospitals. And we think of urgent and emergency care and planned care as the two pillars of what we do. And specifically in hospital, all of our hospitals now are experiencing the pressures that we usually see at this time of year, which is in a sense increased by COVID in two ways. The first of which is there is undoubtedly a degree of activity that occurs just because people present with COVID. But more importantly, the new ways of working that have been forced on the hospitals in order to maintain COVID security means that it's very much more difficult to just run routine care for urgent and emergency care. And so whether you're in the emergency department or in the wards of the hospitals, because it's much more difficult with spacing and PPE, we find that actually just conducting urgent and emergency care is hard work. And you will have heard the stories of people already being delayed longer than they should be in the emergency departments, and ambulances beginning to find it difficult sometimes to offload people. So this is a pressurized time, not only because of the relatively modest amount of COVID illness, but also the impact that the new ways of working has affected our hospitals. But as they are at the moment, they are coping. The other thing to say is you will remember that as a result of the summer that we've had, that there has been a big impact on our waiting list for planned care. And some people are waiting entirely unacceptable lengths of time. You remember last time I reported that we had the bleakest projections were that there may be many thousands of people who find, at least temporarily, that their journey through planned care can last for a year. The news about that is that number is about 4,000 people. But that number is only growing very slowly at the moment because of all of the work that people have been doing, and not at the very high rate that we had anticipated when we were having our bleakest planning. However, that's an unacceptable situation, and people are working very hard. The other thing to say about that is that when we first had our first wave of the pandemic, effectively all of our planned care, other than really extremely urgent care, was suspended, whether that was outpatients or people waiting for operations. We are working very hard this time round for that not to be the case, and that emphatically is not the case at the moment. We are struggling a little to get back to the levels of outpatient activity that we had before in the hospitals, although that's getting better, and of course much of that is virtual contact. But actually the levels of operations, both day cases and for inpatient stays, is not far away from where it was before COVID hit. And the last thing to say about that is that is always impacted. That programme of elective work is always impacted over the summer as urgent care becomes such a priority. But we are working collectively with the whole of the healthcare sector, whether it's primary, community, or the hospitals, and particularly the hospitals working together to try and make sure that there is a degree of resilience across the hospitals, rather than letting each hospital struggle by itself. And so, for example, where there's been a particular pressure in Hampshire hospitals, we've had active conversations with other parts of the county and hospitals in other parts of the county about how we could collectively respond to make sure that we keep as much of this elective work going through the pressurized winter period as we can. We're sort of up against it at the moment, so nobody is systematically cancelling any of that elective work at the moment, and we are day by day keeping an eye on that. And if there are pressures that mean that there's a threat of cancellation, we have a fairly rigorous way of going around all the other options, including the use of our private hospitals in Hampshire and Isle of Wight, in order to minimise the impact of that. So the overall message is COVID is becoming more significant in the hospitals, but not as significant as yet as it was in the first wave. The impact of COVID has made running hospitals much more difficult, and that's putting pressure on urgent and emergency care. But as we speak, our planned care programme is resilient and is benefiting from the way that people are working much better together than they used to be. Ruth, I don't know if you want to add anything more to that, and other than that, I'm sure we're happy to take questions.
Yes, thank you, Andrew. And Councillor Huxley, I might just have a couple of moments just to reflect on some of the other pieces of our work. So primary care, to give comfort to members that we are back into planned recovery levels for our primary care delivery, which of course is really important given the volume of care that is delivered indeed through our primary care services. So that's really fantastic news. And again, our community partners, who again work really hard in our local communities to deliver those services, are again working really hard alongside primary care and hospital partners to continue that recovery programme. And of course, we also have other areas of care delivery that are commissioned by NHS England and NHS Improvement. So things like pharmacy services, dentistry services and optometry services are all back up into those recovery spaces, such that face-to-face consultations and contacts are available across those areas of care delivery as well. So the work within the hospital, as Andrew has alluded to, is progressing well, and the areas outside of hospital around some of those pieces are also developing well in terms of relation to the paper. So I just wanted to draw those elements out. Thank you.
Thank you indeed, Ruth, and I hope that we can now go to some questions. I haven't seen any flags. Councillor Harrison, you're on the mark.
Thank you. Quick off the blocks as usual. Chairman, it's a question for Simon Bryant. I'm aware that you've used your powers, as have other officers in your position, to prevent large-scale public events from taking place. And I think that you'd probably accept that we must try and avoid a situation where we do so at the last moment. You know, things like the New Forest and County Show apparently take a year to organise, and you know that there is a huge impact, not just on the economy, but for the people who've been involved in the organising of it and all the rest of it. And I just wonder whether we're doing any work in order to liaise with these organisations to try and give them a heads up. I appreciate that we're using a crystal ball very largely about what might be the situation in weeks or months to come, but whether there's any prospect of better liaison about you know, the sort of advice and guidance we can give them by way of advance notice.
Thank you, Councillor Harrison. Councillor Huxley, shall I just answer that question? Would that be okay?
Yes, please.
You're right, and I think giving advance notice is what we were trying to do all the way through this. And back in October, we were giving advice about Christmas, because obviously Christmas is coming up on the horizon. There's a number of events, and we've given advice previously around kind of bonfire nights and Halloween and Diwali and things like that. So you're absolutely right. We're trying to be clear, and we do that through our SAG process, our safety advisory groups, which are led at a district level, and we input to those and have been clear what kind of events should go ahead. And obviously these are people's passions and sometimes their businesses, and we want to be really fair to them, as you say, because it's not helpful to cancel at the last minute. However, sometimes that is unavoidable. So we'll be working with each of the organisers all the way through, asking them, and this is what happened with a couple of events, what their COVID safety measures are. And if they say, well, we're going to do A, B and C, we look at that and say, well, actually, that's not safe enough for us. Can you do D and F? And they go, yes. And then they say, well, actually, I can't do one bit. So we have to negotiate with them over a number of weeks and months if we understand what that is. And then sadly, sometimes when we get to the last minute, they say they're going to do something, it doesn't happen. We then have to do a direction. We have only done 2 legal directions in Hampshire, which is really good and testament to the really good work we're doing with our organisers of events. But you're absolutely right, we're giving as much warning as we can, and if people are aware of that guidance, and I think following the period of national restrictions, we'll see some much clearer guidance coming out.
Thank you, Simon. Councillor Darden.
Yes, thank you, Chairman. I've got a question for Graham Allen and Simon Bryant, Chairman. Can I ask Graham Allen first and then go to Simon Bryant?
Of course.
In regards, Graham, I'd just like to say for yourself, all your senior officers, Jess, all of them, and all your staff, you've done a fantastic job, because quite frankly, it's been a mammoth task for yourself. But my question is, and it's been a concern of mine, in regards, because you mentioned it there, 2 tranches of money that you've had in regards of the COVID finances. Is that sufficient, or is there a long way to go as far as the money that has actually been spent? Because of course it was the intention of government initially that you would be recompensed for everything that you spent. Can you answer that first, please?
Yes, thank you. It's a really important question, and there are further financial updates that will be coming through to the Cabinet of Hampshire County Council, setting out both the in-year financial position and indeed the longer term financial position. Essentially what we have is a perfect storm, if I can describe it in this way, in that we've got 3 key issues that are impacting certainly in this year, but also will travel forward with us in future years from an adult social care perspective. And those 3 factors are, we've seen some additional costs of supporting people through COVID. We've seen some lost time in terms of, Jess made reference in her part of the presentation to our transformation to 2019 and transformation to 2021 programmes. Clearly, in terms of our attention and our focus, it's been absolutely on supporting residents through the pandemic, and that's meant that we've had to, for the time being, reduce or cease our activity in terms of our cost efficiency programs as part of our overall transformation to 2019 and 21 programs. So we're behind the curve in terms of those savings requirements. And then there's the third issue, which is we've had to, in terms of our COVID response, above and beyond the support we've had from government, we've had to expend additional amounts of money. And most recently, government grant received by Hampshire County Council, I think it was the 4th tranche of money received by Hampshire County Council, was in the order of about £8 million. And as a local authority, we're identifying that we required something in the region of about 40 million, I think is the figure, in order to maintain our financial stability as we go forward. Having said that, we are in a position whereby in the short term we're able to cover those costs, but certainly as we look forward over the course of the next 2 to 3 years, the total cost of COVID to Hampshire County Council is around about £210 million additional to the money that we've had available to us. So the pressures are very significant as we go forward. Our focus is absolutely on the here and now in terms of supporting our residents through all the work that we're doing. But clearly for myself, for other chief officers, for other senior officers, and indeed for executive members, the medium and the longer term at this moment is looking much more opaque than we would hope it to be from a financial resilience perspective.
Yeah, thank you, Graham. Well, I hope some government ministers are listening in this morning, quite frankly. My second question is obviously to Simon Bryant. You were talking about testing and whatever. Can I ask you, there is a testing station at Hursley Park at IBM, a large one, I understand. Who is that for? Is that for just business, or is it for IBM staff, or is it for the public?
So the testing centre at IBM Hursley is one of the mobile testing sites. It's not there all the time, it's for anybody. So what would happen is if you require a test, you have symptoms and you go on the website to book a test, if that is available in the next few days, that will come up as a local, as a testing site anybody can use.
Okay, that's good to hear. Thank you, Simon. Thank you, Chairman.
Thank you. Dr. Bishop, we've had this news about the vaccine. You obviously have a greater knowledge of these things medical. What is your take on how it might impact for us? I'm particularly concerned about the NHS vaccination program that might stem from it, and the fact that apparently the vaccine has to be stored between 70 or 80, between minus 70 and minus 80 degrees centigrade. That sounds like a huge logistic problem.
It does sound like a huge logistic problem. I think the first thing we would say, of course, is what good news it is for us all, and particularly health service. And I think it's worth reflecting that there really were only ever two ways out of our current situation in health. The first of which is everyone becoming immune by virtue of exposure, which is a very difficult road to go down, or people becoming immune because of vaccination. And if that becomes a reality, that really does mean there is an end in sight. So of course, it's very, very welcome news. The logistics of vaccination on that scale, not least the logistic that you describe, are going to be extremely challenging. I think one of the things that we have as an asset is our new ability genuinely to work together and at scale and with other partners. So this really will be something that health does with lots of other people, including many other agencies. I think that this is probably the first vaccine, but my suspicion is, knowing what I know about what's going on, that we may find that there are a few others that may become easier and at scale. The specifics of how we organize that, we are ahead of the game under the Resilience Forum, and there's a specific program and project under the Resilience Forum that already has an advanced plan for the people, facilities and logistics that would be required to do all of this. But this is really going to be partnership work, because it's going to mean the use of facilities and staff for whom this wasn't necessarily their day job. But I think that it is of such import that it will be our #1 priority to make sure that whatever needs to be done will be done.
Thank you, Andrew. Simon, you look so you need to comment.
I was just going to add to the comments around the minus 70. So yes, you're right. It does have to be long-term stored at minus 70, but actually for delivery, it can be used the normal cold chain, which is through the refrigeration. So as in normal household fridges can be used to store it if it needs a vaccination. So there's kind of two sides to that. And as Andrew said, it's a really exciting development. We also need to be bearing in mind that it's exciting, but it's not immediate. we've got another many months before we'll have population vaccination. So we still need people to manage their social distancing, hand washing, and sorry to be really dull, wearing the face coverings. And it's probably what I say all the time, but really important. But I'm really excited that we have got a vaccination programme that is possible.
Thank you, Simon. That's reassuring. I have a question for you, actually. As you know, Deborah Harkin, Deputy Chief Executive, produces these periodic bulletins for members, and they are extremely useful and comprehensive. Consistently, over the past week or so, she's been describing the infection rate, England, ranging between 2 and 4%. Now, where does Hampshire fit in that? Are we at the 2% end, or are we in the middle?
So the figure she's describing is I think would be the positivity rate. Would that be right? So she's describing the percentage of people who are testing for COVID who are positive.
And it's right.
And our range is around about, I'll just kind of look. I haven't got the Hampshire figure in front of me. Different districts. Havant is at 5.9, and then Test Valley is at 3.3. So we're within that range of positivity, and that means that people who are going for tests with COVID-like symptoms, obviously not as we described before, it's not a clear-cut symptom, who are testing positive. I can get these figures afterwards. Is that helpful?
Okay, thank you. I don't see any more hands raised, members. Oh, Councillor Frankham, just in time.
Right, thank you. Well, there's two things. I'm just wondering what we can do as members. I've had a lot of residents get onto me, fear mostly actually about in schools, but really worried about how the stats seem to be going up. And in actual fact, what you're telling us is, although they are, it's not quite as bad. What can we do to try and help to allay the fears, but in the same time, make people realise it is important that we continue to carry on with government lines?
Councillor Frankham,
Simon, would you like to address that?
Yeah, Councillor Frankham, it's a really interesting point. We don't want to instill fear in people. However, we do need people to be mindful that they need to carry on, because the figures are going up. And, you know, we're not in the place of the northwest of England, but actually it's still concerning. And we need to do that. And how we can keep promoting the messages of good hand hygiene, social distancing, you know, as you say, following the government guidance of not meeting two households together. And I know it's frustrating, and I know it's really difficult for all sorts of different reasons for different people. So if we can continue to do that, that's great. With regard, just picking up your schools point, we have a really good system with schools. We've done a lot of training and webinars with schools over many months now to understand what they can do to prevent spread, which is really difficult because we need our education establishments to remain open, and secondary schools are large, complex establishments. So there's something about that, but we have worked really well. As soon as there's any kind of case, incident or outbreak, we shut any kind of bubble down and isolate them, which comes to my second point. It's really important that we support people to isolate. If they're asked to isolate or have been in contact, they do need to isolate for 14 days. And I can speak personally, having had my son isolate from school for 14 days. It isn't easy. He's stuck in the house for 14 days and he's a sportsman. But actually, how can we do that? So if you're finding, and Graham's department does do the supporting of those shielding people, there are ways, and the districts have ways to support people who are needing that kind of payment. So if we need to support people, we need to do that, but really encourage them to do that, because it isn't an easy thing to do. So a number of things there, but thank you for your support.
Thank you, Simon. Andrew.
Yes, leading on from that, one of the challenges in hospitals at the moment is trying to persuade people to come for care. And that's a really big issue, first of all, because it's important for them. Secondly, because we have put in place extremely safe measures in order to progress with work. But if people do delay or not come, that just builds a much bigger problem, one that we're struggling with already. So we would be very keen. We have some of our things which understandably people are anxious about, where we're even having to ring people to try and persuade them and coax them to come in, and sometimes even the consultants are having to ring people just to try and persuade them. That's a very difficult situation, and if you could encourage people to take seriously their appointments, but also to reassure them that we put everything in place to make sure that those are as safe as they can be, that will help us all, I think.
Can I come back, please, on
yes,
that one?
I saw your hand was still there. Go ahead, Councillor Franklin.
All right. I actually can confirm that, because I was frightened about going up to hospital. I have been up and had an audio test. Unfortunately, it does seem to be something wrong, and I've got to go for a head scan. But the way that we were treated, the safety measures, was absolutely fantastic. And I have been saying to our residents that it is safe. I've been there myself. I'm going back to have the head scan, as long as it's not called off if anything happens. But I think that's one thing we can do, is use social media to let people know, which is what I've been doing. But it is social media, it's so strong. With the schools, we've had reports that in one of our schools that there was 15 children that were proved positive. Actually, it turned out, no, it isn't. There was 3, and there were specific reasons why. So I think we all need to use social media a little bit more.
Thank you, Councillor Franco. Ruth, do you want to add anything at this stage?
No, I think that's fine. Thank you, Councillor Huckstep.
Okay. Well, I have no other questions being indicated, so we can go to the recommendations. You will have seen, members, that all the recommendations for these 3 items are the same, and that's to note the update. So it's really note the updates plural. Are we agreed?
Agreed.
Noted. With thanks to all of the people involved. I mean, a fantastic job right across the piece, Chairman.
Yes, thank you, Councillor Harrison. You've taken the words from my mouth, as it were. We are extremely grateful to the colleagues who've joined us today from the NHS and the contributions they make, particularly when actually it's still a very stressful time for all of them. So thank you very much indeed. And I hope you'll be able to return again, possibly for our January HASC, to continue the COVID story. So thank you all very much indeed.
Many thanks.
Thank you.
Right, members, we now come to the last item on the agenda, which is the work programme. We need to just double check that we're happy with the work programme. Does anyone have any contributions or comments to make about it? No. As you know, last time we did add NHS 111 service to it, so that will be an ongoing project, and we're going to hear more about that anyway in the new year. So that concludes our HASC for today. In fact, it will be the last one of this calendar year, so we will not meet again until January. I hope that you all stay safe, stay well, and have as good a Christmas as you can, COVID circumstances permitting. So thank you all very much.
Thank you.